So this is the definition we all practice, as I say, and I think this last two groups of patients who are at really high risk of cardiovascular disease, and by doing something to these patients, we can reduce the risk burden substantially. But if we look into a bit more depth, we see that there is another way of defining obesity. And I think this definition provided by International Diabetes Federation or World Health Organization or American Heart Association are more pragmatic. So if we are going to assess someone's risk of cardiovascular disease with obesity, then I think this is the one we should be using. And you'll be surprised that, when you look at this number, you start worrying, a waist of 37 inch, that's in European population, is obese. If you go home today and start measuring your hip waist circumference, you will be surprised. And believe me, for the first time ever in my life, I measured my hip waist ratio after doing this presentation. So I will request everyone, if you can, measure it and see what it looks like. You will be surprised. So, basically, the center of obesity, and as you can see the numbers, I'm not going to go in depth in numbers, but I think worldwide is the World Health Organization definition where you have the ratio. In men if it's more than 0.9, or in women if it's more than 0.85, they've been defined as obese. And this clearly reflects that people who has got a ratio in men more than 1, they are at high risk. More than 0.85, they are also high risk. And obviously we have got the moderate risk and low risk. Now, on this slide I'm trying to show you that BMI may mislead you, because someone may have a high BMI, but that's because of the increased muscle mass, not the fat. So, in these two pictures, as you can see, the waist-hip ratio is same, 0.8. Whereas, when you look at the shape and measure the waist and hip, they are different, and the BMI is also different. So, the risk, you see, this person doesn't have, this BMI is high, does not have high risk of cardiovascular disease, because the waist-hip ratio is as same as this person. So, if you are trying to calculate the cardiovascular risk, don't assess the BMI, assess the waist and hip ratios. This cartoon clearly explains, the shape and size of person. This is low BMI, low waist-hip ratio, and he is at the lowest risk. Look at this one as well. Low BMI, low weight-hip ratio, and as you go up, you see this gentleman is trying to show you where it is. Yeah, there we go. Low BMI, low BMI. Just compare these two persons, but the waist and hip ratio has gone up, so he is at a high risk. So BMI exactly doesn't reflect your cardiovascular risk. So what happened in 2004, came along the famous Inter-Heart study, which was conducted by Salim Yusuf, Professor Salim Yusuf, and in that study they took various variable risk factors, irreversible risk factors like smoking, hypertension, diabetes and whatnot, and they took not BMI, as you can see, abdominal obesity, not BMI. Interestingly, these numbers are variable. men, it's more than 102 centimeters, but that again, Caucasian. When you come into Asian men, it's more than 90 centimeters. So what I'm trying to say is that the numbers which is applicable for an European is not applicable for an Asian or a person from the Gulf region. They do vary. So we have to be careful about these numbers. So how big is the problem? The weight of the world, 2.1 billion people are either overweight or obese. And that accounts for 30% of the world's population. That is huge. It is alarming. And as you know, World Health Organization has declared obesity as a chronic inflammatory condition. So it is a disease. It is no more a condition. It is a disease. And if I break down this population figure at various geographical locations, you can see US is at the top. 46% of population is obese. South European 78%. And Asians are not far behind. 32% as I say, on average 30% of world population is obese. And perhaps the North European are the best in this regard. And as you can see, heart disease and stroke is still #1 killer. Then comes cancer, accident, chronic respiratory, and diabetes. Okay? So it is alarming. Whenever we talk about obesity, we're talking about increased heart rate and stroke. Heart attack and stroke, sorry. Now, this is from the HOPE study, as you know, it's a famous British study, which was mainly looking at diabetes. But here, in the sub-studies, as you can see, this type is like, you know, when we talk about patients with higher BMI. This is really high. So sorry, I'm talking about waist circumference now. So this is waist circumference. You can see if this is your baseline, the white one, the CVD depth increases around 1.25 folds. So the bigger is the abdominal adipose tissue, higher is the risk of cardiovascular disease, MI, even all-cause death is high. And then this is about purely coronary artery disease. Again, when the waist circumference goes up, coronary artery disease increases, and it's almost 2.5 times more in morbid obese people. And as you can see, these findings are all clinically significant. Again, another slide which again emphasizes on, you know, abdominal obesity being the second important risk factor for acute myocardial infarction. More important than hypertension and diabetes. So number one is hyperlipidemia, abdominal fat, and then hypertension, diabetes. So lipids, abdominal obesity, hypertension, diabetes. So that's why I say it's a new target for cardiovascular disease prevention, obesity. And this is an interesting slide where you can see they have looked at sagittal abdominal fat. Now that's interesting. How it's been calculated, as you can see, if you lie down and if you put a tape measure from the floor up to the highest point of abdomen, okay, that's the abdominal girth, and then they try to find out about sudden cardiac death. You have got BMI along with it, so this is sagittal abdominal diameter, okay, and this is BMI, and clearly it suggests that the sagittal abdominal diameter is more predictable to define sudden cardiac death. So low obese is the people, the higher the risk of sudden cardiac death. So if you are looking at really morbid obese patient who has got a BMI of 40 or more, they have got a very high risk of having sudden cardiac death. we'll skip this. Now, we're going to try to link this obesity with cardiovascular disease. And whenever we discuss obesity and cardiovascular disease, the first thing comes is cardiometabolic syndrome. I know everyone knows about it. Cardiometabolic syndrome mainly contributes to atherosclerosis, okay, which results in coronary disease or MI and then stroke. But besides that, there are other independent risk factors, which are diastolic heart failure, which is not directly related to cardiometabolic syndrome, and then you've got atrial fibrillation. Along with these comes stroke, obesity. So this is a very sort of famous and popular slide where it tells us that this galaxy of risk factors, high blood pressure, high triglyceride, high LDL, low LDL, intra-abdominal adiposity, which is at the center, core of the problem, insulin resistance, elevated blood glucose, and inflammatory markers, they result in either diabetes or cardiovascular disease. And as you know, my next speakers will discuss about diabetes. So what is metabolic syndrome? I'm just trying to recap. There has to be central obesity. That is number one criteria. So central obesity, along with two of the followings: high triglyceride, low HDL, high blood pressure, and fasting blood glucose, abnormal fasting blood glucose. So central obesity and two of these four will define cardiometabolic syndrome. Now, in our clinical practice, it's surprising. We don't define this patient group because we are not measuring everything and taking account as a single entity. We are still failing to do so. So, after doing this presentation, I have decided now that I will look into any obese patient seriously to find out if they have got metabolic syndrome or not. If they have metabolic syndrome, then I must identify that this is a patient with metabolic syndrome. It is important. Just to show you, there are various ways of defining metabolic syndrome, but as I say, the things to remember is circulatory adiposity and two of these. Now, when we talk about fat, we're talking basically about intra-abdominal and visceral fat. The one which we represented by yellow color. The brown color ones are either subcutaneous fat or intramuscular fat. Now these are harmless, they are not metabolically active. The yellow one are. That's why we keep saying that it's not the weight, not the BMI, but is the abdominal girth which is important. So when we say that fat is metabolically active, what does it do? Because these things, as you can see, there are a lot of cytokines, there are proteins, there are enzymes which are being produced by this active adipose tissue, which in turn eventually cause this dyslipidemia, insulin resistance, endothelial dysfunction, inflammatory process, prothrombosis, hypertension. It also activates the renin-angiotensin 2 system, causing again hypertension, and it downregulates all this. Reduces insulin sensitivity, anti-inflammatory action, and anti-atherosclerotic action. So this is what the fat in the viscera does. So obesity is the new target, that's for sure. Now, you may be wondering why no one has declared it yet, because it will be a chaos. If any country say it is a target, declares target, who has already softly declared that this is a target, but worldwide it has become an issue, and if you declare it, it involves a massive financial burden for a country, as well as we don't have bariatric surgeon like Dr.Girish yet worldwide, because you will require a huge number of bariatric surgeons to tackle this problem. But as a physician, what we can do is definitely lifestyle modification. We have to emphasize on lifestyle modification. I'm a preacher of exercise. I'm a preacher for healthy diets, and we should be emphasizing these things. Counseling is important because, as you know, this is a psychological disorder. So you have to do psychological counseling, and in our center we are involving psychologists to deal with this problem. Medical therapy is there, but medical therapy reduces weight, but it does not improve, it does not reduce mortality. Okay? And you're going to have surgery. People who's going to have surgery, it will be very obvious. They have gone under the surgery, so you cannot do a sort of double-blinded or blinded study. It will be difficult. And the other problem, Dr. Girish may say, I think worldwide is the woman, young women, who usually have bariatric surgery for cosmetic reason or for some other gynecological problem. Men are very few yet to undergo bariatric surgery, and as you know, men are at high risk to develop cardiovascular disease. That's why the evidence is not very strong yet. So anyway, what I'm trying to say is that we do have evidence that surgery reduces CV mortality. From 2012, all of a sudden, worldwide, there was a recognition. As you can see, in JAMA, in Heart, same year, they published some systematic analysis expressing that there is long-term evidence that bariatric surgery improves cardiovascular mortality. And as you can see, this is from 2014, where they incorporated 22 trials, and there was almost 2,000 patients. And this is, mind you, this is a systematic review of the major three research database, Cochrane, Medline, and PubMed. And the conclusion is surgical treatment of obesity yielded greater improvement in weight loss. So there is greater weight loss achievement and weight-associated comorbidities than non-surgical intervention. Regardless of the type of procedure, those certain procedures were associated with greater weight loss and fewer comorbidities than others. So they came to a conclusion that surgery, anytime, some of them are better than the others, but surgery in general improves cardiovascular mortality. Now, I'm going to discuss briefly about SOS trial. This is quite famous. This is one of the first prospective study regarding bariatric surgery and cardiovascular mortality outcome. And as you can see, they enrolled more than 4,000 patients. 50% of them underwent bariatric surgery. The rest of them underwent intensive non-surgical intervention related to, diet and exercise. And this is the outcome. The slide is not very much clear, but I'll just try to explain to you. The top one is the control. That means where you have introduced diet and exercise. And this is, by the way, this is change in weight. So as you can see, there's hardly any change in weight. Rather, it increased around sort of 10 years' time. By the way, this is the longest ever trial which looked at obesity and cardiovascular risk factor, longest. So this is, we're talking about beyond 18 years, right? So control didn't help in weight reduction as such. And then we have got gastric banding. We will come to hear from my colleagues about it. There was a sudden drop in weight, and that is about, I think it's around 18%. And as you can see, after 2 years, the weight will climb up. So there is no benefit. After 2 years, the weight will go up. Now this is gastric banding. The next is vertical gastroplasty. Now this is pure surgery now we are talking about. It's not a procedure. So here you can see there's a significant drop beyond 30%. There is a bit of increment and it stays stable after 8 years or so. But the greatest benefit they looked at is gastric bypass. That's where the greatest benefit was. There was 35% reduction in the weight. Though the weight went up, but still 25% reduction. And then it started to go down. So the surgeries are of various forms, and so far we have proven that at least all of them works, but gastric bypass is perhaps the best one. This slide clearly shows the cardiovascular event. On the left we have got fatal cardiovascular events, and as you can see, it's very interesting. In the first few months, this one is surgery, this one is control. After a few months, the cardiovascular mortality starts to diverge. That means the benefit is quite good, and the benefit goes beyond third and fourth year and runs back. And this is from SOS trial, 4,000 of patients, very important trial. And same here, this is cardiovascular events like small strokes, small MI, not large one, even small events were also reduced from the very beginning after doing surgery. I'm just going to discuss this slide. If you have a look, this is surgery, the right is control. And as you can see, this is talking about events by baseline insulin. If surgery is being done, the insulin level is always high in the control group. As you know, high insulin is not good. It is a risk factor for cardiovascular disease. So, if someone has had the surgery, the insulin level is always below in comparison to the population who didn't have surgery. So hyperinsulinemia is not a major factor after surgery. The insulin resistance goes down. Overall mortality, now we're talking about not only cardiovascular, all-cause mortality. It's also interesting, you see, after sort of fourth year, it diverges. So people live longer if they have surgery, if they are obese. So it is beneficial indeed. I would like to just add here, remember that people who get greater benefits are those patients who are, beyond BMI of 40. So if the BMI is higher, the benefit is higher. So future clinical investigations, we can talk a lot about things. It's a busy slide. But what it's trying to say is that yes, we have evidence, but the evidence is still not strong. We have proven that bariatric surgery is safe, and it does help to prevent heart attack, stroke, and all-cause mortality. We have to have more research in this. Take-home message, not for you, for me, is that I am overweight. Do I look overweight? My friends tell me, Sakib, you don't eat. You're taking a text. When I measure my waist and hip circumference, I'm surprised that I have so much of abdominal fat. Thank you very much.
Thank you, Dr. Sakib. Yes, Dr. Medhat.
Thank you for this presentation. Obesity and so visceral obesity and subcutaneous obesity, which is very important, and of course I will come into that into the anesthetic management of anesthesia. But how this will happen? Why some people get the visceral, why some people get the other type? Is it genetically determined?
Thank you, Dr. Medhat. This is an interesting question. Number one, definitely genetic, but the other factors plays an important role, and these two are your diet and the exercise, right? These are very important You know, you can overcome genetic predisposition to a certain extent, but these two things are important. There was a very important trial published from Holland. This is interesting. You know, Northern Europeans are the healthiest among the world, but they are doing research in obesity. This is a paradox. But anyway, there was a study published from Holland. They looked at 24,000 people. Now, these are not patients. These are volunteers, right? And your answer to the question is, people who exercise regularly and had a diet and kept their waistline low survived more. They survived. I mean, their mortality went down to 23%. So I think two things in life is important: diet and exercise. Because all this extra diet, you see, they go and accumulate in this area. Yes.
But can I be an obese with less visceral obesity? Because if I eat more, I get fat, I get obese. But how can I get obese with non-visceral obesity?
Right, with increased muscle mass. If you have increased muscle mass, then that's what I was trying to show in my previous slide. So if someone has a high BMI, doesn't mean that he is at risk because his muscle mass is more, not the abdominal fat.
Any other question, please?
Thank you for this lecture. I want to ask about you, what you mean by all-cause mortality. Other than mortality, other than cardiovascular. Other causes of mortality.
Right, other causes of mortality.
Directly related to the obesity,
Yes,
not hypertension or
it includes pulmonary embolism, pneumonia, infections, septicemia, and then cancer. All of them are there.
cancer.
Cancer was there.
Which cancer?
Bowel cancer was mainly there, but other cancer was also included. But the problem is, the numbers are very small, so you cannot just say that cancer, the risk of cancer can be reduced by reducing weight.
Any other question, please? I can see few surgeons in the delegates, so let me ask for the benefit of all surgeons. We refer cases to you pre-operatively. When you will like to tell the surgeons a red flag that this patient is very high, can have high mortality or morbidity or very high risk patient, so we should be cautious. So what do you think in your patient you will find that and then you can caution us?
Okay. Whenever you're saying a high risk patient, in obese patient, as I say that they have high risk of cardiovascular. Yes. So if the patient is a male and is not young, when I say it's not young, I'm talking about it differs, your biological age and physiological age differs. So any men above 50 will be categorized like smokes, will be categorized as risk. But again, you have to take consideration of diabetes, dyslipidemia, family history, maybe. There's strong family history of cardiovascular disease. These will account someone to be at a higher risk. If you say very high risk, I'm talking about now a 50-year-old person who's diabetic for 15 years, who's hypertensive, who smokes. I would be considering them as a high risk because he may have coronary artery disease, he may have already have atherosclerosis, which is undetected. And then, obesity itself is a risk factor for anesthetist. I will just take account of the other reversible risk factors in these group of patients. Sometimes you may see a young patient that have a valvular disease. You don't know. That can compromise the whole situation. But I think maybe it's the age, sex, and other risk factors.
Thank you.
Can I just, as it came to my mind, you may be asking me, what are the indications of doing surgery, bariatric surgery, from a medical point of view, right? I think one of my colleagues will show it to you. But let me tell you this, till date, there is no indication for bariatric surgery to reduce cardiovascular risk. So far, diabetes, sleep apnea, and to a certain extent uncontrolled hypertension, these are the 3 risk factors where one may say, fine, send him to a bariatric surgeon. For till now, cardiovascular risk-wise, there is no indication for bariatric surgery, but my feeling is it will become an indication in the near future. Thank you.
Why not? When your slides are showing that it reduces cardiovascular.
Yes, but I think we have to have more evidence. We are just waiting. There are still 2 trials ongoing. Once the data published, I think it will become a stronger ground. Thank you.
Thank you very much. Let me invite our